All right, so we'll now finish up the antihypertensive section and then hopefully go on to some pulmonary stuff. I'm hoping I'll be able to pace it out so I'll at least have some time for a review for the last class for the next test. So hopefully you guys will probably like that, right? Most likely. Okay, I didn't realize I only had one slide left for beta blockers, but anywho, notable drug interactions for our beta blockers. Obviously, these are mainly going to be pharmacodynamic interactions you're going to be seeing here related directly to the mechanism of action. So because these are cardiodepressants, more specifically at the beta-1 receptors on the heart, you can see issues with certainly your non-dihydropyridine calcium channel blockers, so things like verapamil, diltiazem. So you see synergistic effects here on decreasing blood pressure, heart rate, contractility, all that good stuff. If you did have the strange situation where you need to use a beta blocker plus diltiazem or verapamil, you'd want to use kind of lower doses of both, at least see how your patient's going to tolerate it. Certainly you would see a common combination of, say, a dihydropyridine plus a beta blocker, but usually wouldn't see non-dihydropyridines and beta blockers together. And then another agent we'll talk about, some of our alpha-2, I should say alpha-2 agonist instead of blocker, but basically Clonidine, we'll talk more about that in detail, but it also will have synergistic effects. Clonidine being a sympatholytic that decreases catecholamine release from the CNS, which just have increased effects on the blood pressure and whatnot. And again, you'll see that abrupt withdrawal of Clonidine will also lead to some of this rebound hypertension, tachycardia like we see with some of the beta blockers. So moving on, then we'll have our vascular smooth muscle relaxants and also some of our alpha blockers. So we know that the signal coming from the CNS will send out lots of different signals, but some of the main ones that we're going to talk about with these guys are going to be the sympathetic nervous system. And so they're obviously going to be releasing catecholamines, it's your norepinephrine, epinephrine. They're going to be activating several different types of receptors, but certainly on the vascular smooth muscle, what's the main vasoconstrictive receptor we're going to talk about? Alpha-1. Yeah, so that's the main one we're going to be looking at as far as vasoconstriction goes. So if I activate that, if I give it alpha-1 agonist, you see vasoconstriction, you see blood pressure go up. If I give an alpha blocker, you're going to end up seeing vasodilation, and thus hypotension can happen here. And certainly all those rebound mechanisms are still going to come into play here. So anytime I'm dropping the blood pressure, your renin-angiotensin system is going to get ramped up. All that other good stuff is going to happen along with that. Also, if I cut down the signal coming from the CNS directly, which some of our medications will do, you'll see that not only will that have effects on the peripheral resistance, specifically on alpha receptors and things, but it'll also have effects on cardiac output as well. So if you have less catecholamines being released, you're going to be seeing decreases in cardiac output, decrease in contractility and heart rate and all that good stuff. So first thing we'll talk about are alpha-1 adrenergic antagonists. So again, these are going to be reversible blockers of the vascular alpha-1 receptors. They're basically going to cause a reduction in total peripheral resistance. You can kind of think of their effects very similar to the dihydropyridines, right? Because they're working more preferentially on the vascular smooth muscle than they are specifically on the heart. You'll see dilation of these precapillary arterioles, and then you also are going to see that reflex increase in heart rate, right? Because anytime you drop your total peripheral resistance, the heart is going to want to respond by increasing cardiac output, so typically that can have an increase in heart rate. So first one we'll talk about, and you may hear different pronunciations. I say Prazosin, some people may say Prazosin, but anywho, so this will be a selective alpha-1 antagonist. You will see some actual positive effects on the lipid profile, but they're pretty modest, so it's not like you'd ever be on this medication specifically for this. And a lot of these medications you're going to see in combination with either diuretics or beta blockers, because by themselves they're kind of crummy antihypertensives. They might be good for kind of kind of short-term acute decreases in blood pressure, but your body's going to want to compensate for that. It always wants to maintain homeostasis. So, if I give an alpha-1 blocker, you're going to end up having increases in heart rate, and so it doesn't really work great by itself. And as we have gotten out of the beta blockers and calcium channel blockers and ACE inhibitors, these are going to be agents that are less likely to be used by themselves as antihypertensives, mainly because the side effect profile is going to be worse than a lot of the other drugs we see. And none of these really have any kind of mortality benefit like we saw with things like beta blockers or ACE inhibitors. Big side effects you're going to see here, one of which is going to be orthostatic hypotension. So obviously if I'm blocking these alpha-1 receptors and you have a patient who's sitting down and all of a sudden they stand up, usually your brain's response to compensate for that is to release more catecholamines to squeeze down on the blood vessels, right? That prevents that orthostatic hypotension. But since I'm blocking that response, orthostatic hypotension can occur. You can have fall risk. You can have acute changes in mental status for your patients that may lead to them to fall, which can be a big deal. Also, you can have some postural dizziness, so headache, drowsiness, lack of energy can occur as well. Obviously, your older patients who have less kind of physiologic reserve are going to be more prone to this than your, say, a young, healthy patient. We mentioned that mild reflex tachycardia that can occur due to that activity of blocking the alpha-1 receptors, decreasing total peripheral resistance. Thus, you're going to have increase in heart rate because of that. You'll also have those reflex mechanisms of increasing renin, increasing sodium and water absorption, and then also sexual dysfunction can occur here as well. So anytime you're kind of changing blood flow to different areas of the body, you can end up inducing impotence in some patients, which may be a pretty intolerable side effect for some of them. Again, like with all of our antihypertensives, NSAIDs typically will attenuate the response to these type of drugs, mainly by decreasing the prostaglandin synthesis, affecting that afferent arteriole, going to the glomerulus. You may end up having beta blockers and other things that are decreasing cardiac output, actually enhancing postural hypotension. And so you do want to be caring patients who have either cardiac or renal failure, just because they have less of that kind of homeostatic reserve to really deal with those changes in blood pressure, especially with standing. Other ones that go into this category as well are going to be Prazosin and Doxazosin. So those are going to have very similar side effect profiles, very similar activity as you would see with our first agent we talked about. Yes?
You put a lot of the molecular structure here. Is that going to be something that...
No, it's just kind of for reference. I'm kind of a nerd, and so I just leave those stuff in there.
Okay, just making sure.
Yeah, that's basically it. I may use some chemical structure just to show similarities between things, but for these, I just kind of leave them in there. Yeah. Mm-hmm. You have to draw all those out, and then.
I just want to make sure.
No, I had a medicinal chemistry class for several semesters in pharmacy school. We had to draw out a lot of reactions and drug structures, and I swore to never inflict that up on anyone in my entire life, not even my worst enemy. So you guys don't have to do that. So some other agents you can see, you can actually have selective alpha-1 antagonists. So those other agents we talked about will basically work on any alpha-1 receptors, but there's certain subtypes of alpha-1 receptors that will be found in different areas of the body. So you can see some of these being used as antihypertensives, but more often you'll see them being used for things like prostatic hyperplasia or BPH to can actually help to decrease squeeze of the prostate on the urinary tract, so that way your gentleman can have easier time going to the restroom. Some of them will also have kind of longer half-lives, so they actually allow for just once daily dosing. So some of the other agents were kind of shorter acting. You may have to dose several times throughout the day. So Tamsulosin or Flowmax, imagine where they got that name from, be one of these agents. This actually works as a selective antagonist to the alpha-1A receptor. And so the main indication here is going to be for BPH. So the benefit here is because it's more selective, you don't really see a lot of hypotension develop from it. And so you don't really have as much things like orthostatic hypotension as you would see with something like a non-selective alpha blocker. Still, you run the risk of seeing hypotension and dizziness, but it's less likely as you would see with some of these other agents. We'll talk more about this when we get to, we're talking about urology stuff in the next class. We mentioned some of these mixed antagonists, and so these are mainly going to be our third generation beta blockers we're going to talk about here specifically. So things like labetalol, this one is a beta blocker, but it does have some alpha-1 antagonistic effects. It's a relatively minor effect, but it does kind of give you some synergistic effects on lowering the blood pressure. So, if you have a patient who is, there's not a ton of beta blockers that come IV or in IV preparations, but labetalol is a really good one for dealing with acute hypertensive, either urgency or emergency. So it's a good one you can just give an IV dose of, and it has pretty good effects on lowering blood pressure and heart rate. Carvedilol is another one that will have some alpha-1 antagonistic effects. This one is going to be oral only, and so you'll see it for more things like blood pressure issues, but you may see it also for patients with CHF. It's one of those ones that's approved and has some mortality benefit with that. Yeah.
What does activity 10 to 1 and 5 to 10 to 1 mean?
That's just a ratio. So When I mentioned that drugs have like kind of multiple mechanisms, so looking at labetalol, has effects at the blocking beta receptors. It also blocks some of the alpha receptors, but it's not like a one-to-one thing, right? It's not affecting all receptors equally. You'll see that based on their chemical structure and how they interact with those receptors, there'll be kind of ratios of how well they work to it. So labetalol is primarily a beta blocker. It probably has 5 to 10 times the activity at beta receptor as it does to an alpha receptor, but you still do have some activity there, right? And if I kept increasing the dose, eventually I could just continue to kind of capture more of those alpha receptors. But clinically and therapeutically, this is kind of what you would end up seeing.
What's ISA?
ISA is that intrinsic sympathomimetic activity, which means that they will have some degree of agonistic effects at particular receptors. I mentioned that a little bit in the beta blocker section. Clinically, they don't come up all that often, but here you can see that the ISA is actually beneficial here because, we said beta-1 receptors primarily on the heart, right? You're dealing with increasing heart rate and contractility. Beta-2 receptors, what do those mainly do?
Respiratory.
You see in respiratory, what do they do in the respiratory tract? Yeah, so they relax smooth muscle. So same thing happens on the vasculature. You do have some beta-2 receptors on the vasculature, and so by giving something with some small degree of ISA at those beta-2 receptors, it kind of helps with the antihypertensive effects, right? It helps to vasodilate some of that smooth muscle. You would never use it as a treatment for asthma by any means, but it certainly can help with the blood pressure. So, good questions. Okay, moving on, then we'll have our central sympatholytics, which basically means that these are decreasing the activity of the sympathetic nervous system. Just a fancy way to say it. So essentially what we're going to be seeing here is that by stimulating these alpha-2 receptors, these will decrease the amount of catecholamine outflow coming from the CNS. So by working up in the brain, you decrease the sympathetic nervous system activity throughout the rest of the body. And it's through these alpha-2 receptors. Typically what's happening in the brain is whenever your body's releasing catecholamines like norepinephrine, the way it turns off that signal is by these autoreceptors. So basically it's kind of a negative feedback loop. So whenever you have too much of the catecholamines floating out in the synapse, it can kind of go back, activate those receptors and say, hey, we have enough, and decrease transmission. These drugs are working directly at those receptors to decrease transmission in the first place, right? So you imagine less catecholamines going to be flowing out. It's going to affect every part of the cardiovascular system, not just the blood vessels, not just the heart necessarily. We talked about drugs that act very similar to this when we talked about some of these imidazoline derivatives. So if you guys remember some of our ENT vasoconstrictors, so things like oxymetazoline, tetrahydrozoline, things like that, those are imidazoline derivatives that are also thought to work at these imidazoline receptors. They have very similar activity to your alpha-2, so don't get too hung up on the imidazoline stuff. Clinically, they all work very, very similarly. So again, probable sites of action, you're probably working in places like the nucleus solitary tract, the ventral lateral medulla. Don't get too hung up on that either where it's working in the brain, but just know that by activating these sites, you're going to be decreasing the amount of sympathetic activity. Again, you see an example of Clonidine here. By activating those receptors, working on alpha-2 receptors and on these imidazoline receptors, you'll have a decreased sympathetic activity control centers, and it's going to release less norepinephrine onto the blood vessels, and that's where you see the main antihypertensive effects happening here. It's also going to be working on the heart as well, and you end up seeing decreased cardiac output. So again, general hemodynamic effects is going to have a very balanced decrease in kind of all facets. So you see a decrease in total peripheral resistance, you see a decrease in heart rate, and a decrease in cardiac output. So as opposed to something which works preferentially on the vascular smooth muscle, you don't really see that reflex heart rate here because this is a decrease in sympathetic activity to the entire cardiovascular system, right? That makes sense? So if I were to ask a question and I were to say something like, patient accidentally took a double dose of his heart medication, he doesn't remember what it was, but his blood pressure is, 60/30 and his heart rate is 150, you would not assume it's a Clonidine that he was taking. You'd probably assume it's something more like a dihydropyridine or assume it's an alpha-1 blocker, right? So looking at the cardiovascular status and looking at the vital signs, you can kind of have an idea of what type of drug they might have been exposed to. And so that's really important for me, like in the toxicology world, because even if I don't know what someone has overdosed on, by looking at their vital signs, I can at least have some idea of what they might have been exposed to, whether it be a beta blocker, calcium channel blocker, things like that, right? If I were to look at someone and they had, say, bradycardia and hypotension, I might think something more like a Clonidine, or I might think, a non-dihydropyridine calcium channel blocker. So clues like that can kind of key you in when you have someone who has kind of an unknown presentation, so from the tox side. So some advantages of using drugs that work as a sympatholytic. So again, you're having a decreased total peripheral resistance with kind of a modest decrease in your cardiac output. The efficacy is really going to be independent of anything like age, gender, or race. So it's really going to be working very similarly in all of your patients. And it could be suitable for monotherapy, right? So alpha-1 blockers you wouldn't use by themselves, but potentially Clonidine you could. Works good in elderly patients. We use it quite a bit in some of our pediatric patients for blood pressure control in the, say, in the cardiac ICU. And also has no negative effects on lipids, which is another benefit here. Anyone know any other indications where you might see Clonidine being used? Not for a cardiovascular disease?
Psych?
Yeah, what kind of psych?
Schizophrenic?
Nope. Something like it's pediatric condition primarily. ADHD, absolutely. So you can certainly see Clonidine. So sympatholytics can be utilized for ADHD. So you'll see, if you ever see kids who are like, say, on amphetamines during the daytime, then they're on like Clonidine at nighttime or Guanfacine at nighttime, that's typically what they're being on it for. It's not necessarily for blood pressure control, but more for the ADHD aspect. We'll talk more about that when we get to our psych section, but just be aware that if you see people on that, they may not necessarily be on it for blood pressure effects, more for the ADHD. Basically, give them a stimulant in the morning, and then you calm them down at night with one of these guys, right?
How about right after school?
Right after school, absolutely. So some other side effects, just like we were kind of alluding to the ADHD stuff, these do have kind of a depressant type of effect because you're basically decreasing sympathetic nervous system across the entire body. So drowsiness, sedation are certainly common side effects here. Dry mouth that you can see. Sexual dysfunction as well, and then it really has a kind of a narrow therapeutic range. So this is something that even small changes in dose can potentially lead to some big changes in blood pressure and heart rate. This also has like a patch that's available. So if you ever see Clonidine patches, that's actually good because Clonidine itself has a pretty short half-life. So you may see a dose, for hypertension, say 3 times a day. You can get away with the patch and apply it. I think the patch might be every 3 days. I can't remember off the top of my head, but basically the patch will allow for transdermal absorption, allow for kind of more extended duration of action. Other thing you see with patches is that when you take a patch off, is it completely out of drug? It's not, right? Because in order to drive drug across the skin, you need to have a good concentration gradient. So in order to get the same kind of delivery of drug throughout the entire time period, you need to have a good concentration gradient that whole time period. So if you take a patch off, throw it in the trash, it still has a lot of drug on that. So if animals get into it, people get into it, it can really be a big problem, especially if they're getting nice extended release preparation right in the stomach. I actually had one pediatric patient who presented to the ED, was bradycardic, hypotensive, lethargic, couldn't really figure out what had happened, and so we were talking to the parents and trying to figure out what was going on. And Dad's like, yeah, I'm on a Clonidine patch. And I was like, well, this looks a lot like Clonidine, And Dad's like, there's no way a kid could have gotten into this. And the kid was like, 6 months old. Like, he wasn't really moving around much to get into the garbage. And I was like, does he have any siblings? He's like, yeah, he's got like a little brother who's like 2. And I was like, I bet the 2-year-old fed it to the baby. They're like, no way, it couldn't have happened. So anyway, so we ended up treating it. There's a specific antidote you can try and end up working. So we're definitely thinking Clonidine. Sure enough, 3 days later, kid pooped out a patch. So I was like, yes, got it. I would have felt real dumb if that never happened, but I felt vindicated that day. No.
How big is the patch?
It's a fairly small patch. It's not real big.
Polyamine kind of size?
I haven't seen one in a while. It'd be kind of similar to that. Yeah, it's not like a big Duragesic like fentanyl patch or anything. But certainly, a kid could swallow it. Yeah. So anywho, so it has an narrow therapeutic range. So certainly, big degrees for toxicity are possible. And then you also have that abrupt withdrawal syndrome that can happen. So again, if you're on Clonidine for a prolonged period of time, your receptors are going to upregulate or downregulate. What do you think? Think downregulate? Because we're giving alpha-2 agonist, right? And so we're decreasing the amount of catecholamines that are outflowing. So you may think, yeah, they would downregulate from the alpha-2 standpoint, but everywhere else in the body, what are your adrenergic receptors doing? they're upregulating, right? Because they're not being activated by the normal catecholamines that they're used to. So they actually start upregulating. So if I were to remove the clonidine abruptly, now all of a sudden you're spitting out more catecholamines, all those receptors are being activated now, and so you can see abrupt increases in blood pressure, which can be pretty problematic for some of your patients. So it's very, very important to make sure your patients are kind of titrating down off of clonidine slowly rather than just abruptly withdrawing from it. So I said clonidine is kind of our main agent here. We also saw some agents that are very similar to this being used for glaucoma. Just remember any of those? Like brimonidine would be one of the ones. So again, these are working very similar to those agents. This one is just able to cross the blood-brain barrier and work in the CNS. So again, it's going to have, acutely, you can actually end up seeing vasoconstrictive effects, but clinically, when you're taking therapeutic doses, you don't really see that. So again, we're going to be seeing increased or decreased sympathetic nervous system effects. We're going to see increased parasympathetic effects as well due to this. And then you can actually end up seeing some inhibition of insulin secretion. So increased glucose is another possibility here as well. Some other random effects you're going to be seeing is that it will decrease ADH secretion centrally. Does cause some sodium retention similar to other antihypertensives, so you may see this used in combination with something like a diuretic to kind of help blunt some of those effects. Again, sedation, dry mouth are going to be some of your main side effects you're going to run into. And actually something you might see clonidine also being used for is actually for certain pain conditions. So certainly if you have a patient who is withdrawing off of something like an opiate, say, especially over at Nemours, like, specifically if you're dealing with a baby who has neonatal abstinence syndrome, so say mom was abusing opioids during pregnancy, that baby's being exposed to all that stuff. So when they come out and now they don't have a source for that drug anymore, they start to withdraw. So they get very hyperadrenergic, they get, very cranky, very hypertensive. So you can actually give clonidine and help blunt a lot of that response. So if you ever see like little neonates on clonidine, that's one thing. If you see someone who's withdrawing from other opiates, potentially that could be another source there. Clonidine itself actually has some analgesic properties as well within the spinal cord. And so we actually, for some of our epidurals that we'll actually administer, say in a post-operative setting, we'll actually mix some opioids along with this small amount of clonidine, and actually will help blunt some of that, some of the pain responses the patient's receiving. So lots of uses for clonidine, but for these purposes, we're mainly going to focus on the antihypertensive effects. So we kind of mentioned this. Certainly, orthostatic hypotension is going to be a big possibility here because, again, not only is their total peripheral resistance down, but now their heart rate can't really respond as it normally would because you're decreasing the adrenergic response there as well. Impotence, bradycardia are all possibles in addition. Another drug that's very similar to clonidine is going to be Guanfacine. So this is a less potent agent. You see less sedation with it, and occasionally you may have some withdrawal syndromes, but I don't see this one being used quite so frequently for hypertension anymore, but I certainly see it a lot more for ADHD. There's some extended release preparations that are available. They're good for a full 24-hour period, but certainly ADHD would be the big source I see here.
And
Good.
again, this is to bring them down off their stimulants?
Typically, or if the kids are just like way too overstimulated in the first place, they can help kind of tamp down that adrenergic response, right? But most often what I end up seeing is that they'll, because like your first line for ADHD is going to be stimulants, right? And so if the kids are still super wired, towards it, usually you're using short-acting agents. Depends on the kid, but basically on when you need them to be kind of focused, you may see these being used as kind of to bring them down in the evening. Okay, the last group we'll talk about in this section is going to be our direct vasodilators. These are going to be more agents that we're going to see being used for short-term hypertensive issues, right? So if you have a patient who's coming in to the ED with blood pressure of 200 over 120, like these are the kind of drugs you might be using to deal with these blood pressure issues. So these are going to be direct vasodilators, so they're going to typically be working directly on dilating the arteries, decreasing total peripheral resistance, and of course you're going to see a lot of these sympathetic effects as reflexes. So tachycardia, increased cardiac output, fluid retention. These are typically short duration agents, so you can oftentimes these are going to be bridges to other therapy for more chronic management of the blood pressure. But and you will see that for some of these agents, you actually have some tachyphylaxis that occurs. And you guys remember what tachyphylaxis means? Of course you do. Right, just like nitroglycerin, right? So eventually, with some of these drugs, as you keep increasing the dose, your body's physiologic response is that you don't really get any extra benefit out of it because you're kind of running out of either cofactors needed in order to keep the drug effective, things like that. So at some point, you're going to run into kind of a plateau where you don't really get any extra benefit out of increasing the dose for these drugs. So a couple ones we'll talk about here include hydralazine, Minoxidil. Anyone know what Minoxidil is also known as? Rogaine, absolutely. Nitroprusside, and then diazoxide. So clinically, what we can see used for chronic hypertension, usually in combination with other medications. You don't want to use these by themselves. Hydralazine might be utilized. You may see this being utilized for more chronic management of hypertension, but it's kind of a crummy drug as far as adverse effects go. So where I see it more often is going to be intermittent IV doses to deal with hypertension. Minoxidil as well, but really you don't see this being utilized as an antihypertensive, more just for the topical application. But I'll mention it here just for completeness sake. And if you're having like a true hypertensive crisis, these are medications that are fairly short acting that will be administered as continuous infusions. So things like Nitropruside, diazoxide, and then Fenoldopam. So hydralazine is probably the more common one you'll end up seeing. Notice hydralazine is a very common drug to get mixed up with a different drug that sounds very similar. Does anyone think of anything? Hydroxyzine would be the other one. Remember, hydroxyzine is an antihistamine that we have, and that's a very, very common look-alike, sound-alike type drug. You don't want to get that screwed up, right? So I don't want to give my patient who's having allergies hydralazine because all of a sudden they're going to be like feeling really crummy because their blood pressure is bottoming out, right? And vice versa. So be careful when you're looking at hydralazine versus hydroxyzine. It's a very common medication error. We don't have a full idea of what the mechanism is here. Some people think it's related to increasing nitric oxide. And we remember that nitric oxide is going to be a direct vasorelaxant, a vascular smooth muscle. Also thought to maybe interfere with some calcium movements, maybe some renal prostaglandins. But mainly the thing you're going to see here is direct actions on the vascular smooth muscle. So again, kind of a complicated picture, but the main thing to focus on here, and this one will come up again as we go along, but you see calcium coming into those. Remember our calcium channel blockers, they work on T-type or L-type channels? You guys remember? I always think the T-types are terrible. You don't want to do that. So the L-type channels are really the ones you want to do there. So calcium's coming in, it's releasing calcium from the sarcoplasmic reticulum, causing vasoconstriction. But the one thing we can do is inhibit that effect with cyclic GMP and nitric oxide. So something like nitroglycerin would actually work through the same pathway, very similar pathway, just maybe at a different step. But by doing that, you have an inhibitory effect, and so you cause smooth muscle relaxation. So one of the big things to note here are some of the adverse effects that we can see and some of the pharmacokinetic differences that patients can have. So the way that hydralazine is metabolized is through acetylation within the liver, okay? So some people are going to be fast acetylators, and some people are going to be slow acetylators, right? It's just a genetic difference we have, and it's really hard to determine who might be a fast or slow acetylator just looking at somebody, right? You can do genetic tests, but honestly, the testing isn't really cost effective enough to do at this point. You can't really get results back quick enough. So you kind of just dose the drug and see how they respond to it. So the fast acetylators, people who are metabolizing the drug more quickly, do you think hydralazine is going to be more or less effective? Should be less effective, right? Because if I'm just chewing through the drug because they're a really fast metabolizer, they're not going to get as much effect. So I may need to actually increase my dose to overcome this. On the flip side, if I have a slow acetylator, my drug level should go up or down? Should go up, right? Because I'm not metabolizing the drug as quickly, right? So slow acetylators are more likely to accumulate drug and more likely to develop some of these side effects. So the big thing you can see here is that especially for slow acetylators, they can develop this lupus-like syndrome that can occur. Especially with high doses, especially with long-term use, females tend to be more prone to this. And then slow acetylators, and Caucasians as well, they end up developing like that kind of butterfly rash on the skin. Looks very much like lupus when really it's just related to the hydralazine that they're on. So a couple of drugs can do this, but this is one of the big ones to make note of that can cause this.
So, does that mean that the Caucasians of the group are actually more likely to be slow acetylators?
Yeah, there's probably a higher percentage chance that they're more likely to be a slow acetylator, right? So your slow acetylators are going to be the big ones to look here. Again, we can also see some reflex issues here as well. So because we're causing that vasodilation, you're going to see increases in cardiac output and also fluid volume because your body's trying to maintain that homeostasis. So it would be contraindicated in pretty significant coronary artery disease, because anything that's going to be causing big increases in cardiac output is going to increase oxygen demand by the heart. So again, if they're more prone to ischemia, that can worsen that. The elderly typically don't do quite so well with this drug, mainly due to the orthostatic hypotension effects. And then potentially like the ischemia, we kind of mentioned that already with the coronary artery disease. Another thing, I always mention if something turns your excretions a different color, you should make note of it and let your patients know, because otherwise they may freak out. Because if you see dark tarry stool, what do you think? GI bleed, right? But your patient may just be on hydralazine, so let them know their stool may turn black. Does anyone know anything else that may turn your stool black? Pepto-Bismol, anything else? Iron can do it too. Yeah, absolutely. So anything that turns your stools different colors, you should let someone know. Another drug, so Minoxidil, actually was originally marketed as an antihypertensive, but then they all of a sudden realized that this actually works better as for growing hair. But the way that it's actually working is by activating these potassium efflux channels. So by opening those channels up, you kind of hyperpolarize the cell and prevent it from actually constricting quite so much. So here you can see the channel, that potassium channel, basically just opens that up and lets all the positive ions out and kind of hyperpolarizes the cell. So it can't actually cause that squeeze to happen anymore, right? So very significant hemodynamic effects here. You can see big changes in blood pressure and big changes in cardiac output as well, because your body's really trying to respond by really pumping up the cardiac output to deal with that decrease in total peripheral resistance. So it's very difficult to use as an antihypertensive. That's why we don't do that anymore. I actually had a patient who, if anyone's looking at Rogaine, you can actually see has a pretty significant alcohol content in order to get the drug into solution. I actually had one patient who was homeless and was an alcoholic, couldn't find any alcohol, so I think he was at a Walgreens, looked at the Rogaine and said, hey, this stuff actually has alcohol in it. I'm going to drink this. Drank a bunch of it, and all of a sudden he comes in, blood pressure's just in the tanks. He's tacking away like crazy. I think we ended up having him on 4 or 5 different pressors at one time. So dopamine, epinephrine, norepinephrine, vasopressin, all kinds of different stuff in order to keep him at a reasonable blood pressure, so at least be perfusing somewhat. Probably for several days, probably 3 or 4 days, we had him on all those pressors in the ICU because this drug has a long half-life, it's very lipophilic. But so very difficult to use as an antihypertensive. The reason why we mention it, though, is that even though typically your patients will be using it dermally, if you had someone who accidentally ingested it, that could be a problem. Or you can actually, for people who maybe are using too much of it or applying it too frequently, you can potentially see systemic effects from absorption through the skin. So you may even see hypotension related to dermal use. Okay. Another drug is Nitroprusside. This one's kind of interesting because it's a direct vasodilator. This is going to be used a lot for continuous infusion drips for extremely hypertensive patients. This one's interesting because it's actually 1 nitric oxide molecule bound up with 5 cyanide molecules. Sounds like a good idea, right? I'm going to pump my patients full of cyanide, right? So essentially what's happening here, though, is that the nitric oxide can be liberated and will activate cyclic GMP, very similar to what we saw with our hydralazine, and this decreases intracellular calcium concentrations, decreases the amount of squeeze you have on the vascular smooth muscle. It's going to affect veins and arteries pretty equally, and again, like I said, it's going to be given by a continuous IV infusion. So does anyone see any problems with giving your patient cyanide? Probably, right? So it's probably an antidote we might use to help decrease some of the effects here. But your body produces cyanide normally anyway, right? Your body can detoxify it to some degree, but in some patients you actually see accumulation of this that can lead to problems. So certainly if I have a patient who has liver dysfunction, they can accumulate more of that cyanide, leading to things like trembling, vomiting, convulsions, very severe acidosis potentially. So we actually give a drug called sodium thiosulfate. And sodium thiosulfate is actually, what we did at Nemours is we'd actually compound the drug together. So if you order nitroprusside, it automatically came with sodium thiosulfate already in it. And what it does is it gives sulfur molecules over to the liver to allow it to metabolize the cyanide more efficiently, right? So by doing that, you end up producing this molecule called thiocyanate, which normally you just pee out and it's not a big problem. But if you have patients who have, say, renal dysfunction, then they might actually accumulate some of this thiocyanate. So you can see weakness, anoxia, tinnitus, all kinds of other problems related to this. So it's a drug used for short-term use. Typically don't want to use it in patients who have really poor renal or hepatic function, but it's a very good antihypertensive in emergency cases. Fenoldopam is another one you might see being used as an antihypertensive for kind of emergent cases. This one's actually a dopamine receptor agonist, and so it's going to be working more directly at the kidneys in order to help stimulate vasodilation to occur through these dopamine receptors. It's going to have some direct renal effects as a diuretic, but mainly it's going to act as a vasodilator through these dopamine receptors. Again, things you can see, headache, flushing can potentially happen. Also, dysrhythmias are a possibility, so that's why we really recommend short-term use. So normally what you have is, patient comes in, hypertensive, crisis. You get them started on one of these short-term vasodilators and then eventually bridge them over to something either oral or something they can give more intermittently, something like maybe labetalol or something like that. So, how do we decide what to give our patients, as far as treating them for hypertension? So JNC8 is the guidelines to go to. Those are the main ones you're going to reference when treating patients with hypertension. And changes haven't been too radical for the most part, but essentially what we're looking at is our goal for our patients, including with diabetes, including with chronic kidney disease, want their blood pressure less than 140/90. Okay, it's kind of the goal if they're above that. As far as what drugs to use for who, basically what they say is that for black populations, they recommend, even if they do or do not have diabetes, you really should start treatment with a thiazide diuretic or a calcium channel blocker. Okay? Basically because they're more likely to have salt-sensitive hypertension, and so they respond better when you start out with something like a thiazide or calcium channel blocker. Okay? For all the other patients, you kind of can use whatever you want. So maybe a thiazide, maybe calcium channel blocker, ACE inhibitor, ARB, whatever you like is probably going to be fine. Those are your main classes of drugs you're going to be starting out with. Notice you don't normally start with a beta blocker, a lot of it related to exercise intolerance and things like that. In chronic kidney disease patients, though, you definitely want them to have either an ARB or an ACE inhibitor on board. Why is that?
They act outside the kidney.
Well, remember they're renal protective, right? They're going to help prevent a lot of that renal remodeling that can occur, especially for your diabetic patients. You're going to potentially have some of that the nephropathy that can happen there. So for chronic kidney disease patients, ACE inhibitors are going to be critical for them in order to help prevent further progression of disease. So essentially what you're going to be doing is you're going to dose your medication, typically give it about a month or so, and then look to see how the blood pressure is doing. So at that point, you can either increase your dose, or if maybe the side effects are intolerable, you can maybe switch over to a different type of agent. So say you had a patient you started out with hydrochlorothiazide, and for whatever reason they just could not tolerate it, then you can try a calcium channel blocker, usually like a dihydropyridine, something like amlodipine, right? And then as we go along, we'll find other situations where you're going to recommend different agents based on their disease state. So if they have diabetes, we'll see which ones are more recommended for them. If they have previous MI, we'll see which ones are going to be recommended for them. CHF, similarly. So as we talk about those individual cases or individual disease states, you'll see where we're going to recommend those drugs. And all of that's going to kind of go back and treat their blood pressure anyway, right? So you'll see how that goes. Any questions on this stuff? Alrighty. So we'll go ahead and finish up here, and then we'll do, I'll probably give you guys a 10-minute break, and we'll come back and do the pulmonary section. Work? All right.